Welcome to the JetSet Physical Therapy Podcast. We're here with Chris DaPrato. Did I say that name correctly?
Yeah, DaPrato. That's
DaPrato and Jay Bott. Myself, I am Randall Glazer. Jay and I are the owners of JetSet Rehab Education, and we are holding a course with Chris this spring in Cabo, San Lucas. So we wanted to interview him, and just so people that are thinking or they're on the fence about signing up for this course, they can see what they're getting into, and
Absolutely.
get a little taster, little appetizer for the course, and then do the rest in Cabo, I hope.
Yeah, I've never been to Cabo, so I'm super looking forward to it. I mean, and I live in California, so it's kind of shocking that I've never made it that way. But out of all the places I've gone, Cabo has not been one of the check boxes yet, so I'm excited.
All right, well, welcome to the show.
We're looking forward to having you out there. I think it's going to be a blast.
You're going to love it.
Yeah, it's super fun. And I think this type of approach and technique translates well into people that are excited to come out and get an experience, not just of like education, but like feel things in your body and like have a transformative experience on both science as well as like movement exploration, because our course is all about movement and understanding the efficiency of motion and how we can improve all of that using cups and targeting fascial elements and some of the fascial science out there.
Okay, well, I'd like to ask you a couple of questions. We kind of opened it up to our social media, and we got a few questions in from
Awesome.
people that follow us. And then before we did that, though, we wanted to ask you a little bit about your journey. Like, how did you get into this modality?
Yeah, absolutely. So coming out of PT school, I was actually, I didn't even go straight into a PT clinic. I was doing a lot of performance training and personal training on the side during grad school. And so everything that I was geared towards was really strength conditioning, program development, periodization, working with a lot of different clients that are on the weekend warrior side, and then some athletes that are trying to get into efficiency of training and getting a better kind of handle on their sport and things. So I was really geared towards a very exercise-based PT approach. And then I started exploring a little bit of like the Mulligan aspects of, mobilization with movement and some of the different things you can do with PNF patterns as you incorporate that into strength and conditioning. And I found that it was really fun, and I was gearing it towards sports, and I really wanted that, sports medicine dream job that everybody kind of touts and thinks of when they're getting into this field.
Mm-hmm.
But I found that when I got to that dream job sports medicine program, it was at Cal Berkeley, and I started there doing pretty much full-time athlete care, that my hands were just taking a beating doing all this movement and, hands-on modality aspects. And it really just, I think, threw me for a loop, because I enjoyed the athlete care, I enjoyed the sports medicine environment, but I felt just like a truck ran over me every day in terms of the amount of workload that my body had to go through to help these offensive line guys playing football or these big rugby guys try to rehab some of the things that they had. So I really was kind of thrust into an idea of getting more efficient with manual therapy in that environment by looking at tools. And at the time, Graston had just kind of gotten bigger, and some of the use of like washout tools. And then I got exposed to, from an acupuncturist, this idea of cupping. And she used fire cupping, and the fire cupping that she used was actually to treat my shoulder. And I had some labral issues after playing volleyball a lot. And she went through and she did this fire cupping, and that was really cool. But as she laid me down prone, as they typically do, she was like, all right, you're just going to lay there for, 15 minutes or so with these cups on. I was like, well, I want to move. Like I'm a movement therapist. Like I want to actually get my shoulder moving while they're on there. And she's like, oh, no, you don't do that. That's not the way it's done. And this was like 2006. And I was really intrigued with this modality, but I found that when I started moving, it pulled on tissues, and it had this like kinesthetic sense of things that was so different than anything else I'd ever experienced with foam rollers, with scraping tools, with, manual therapy, hands-on care. And so I really enjoyed the way that felt. And I actually had more relief from that one session for my, like, being able to go back to play volleyball and block and, have full range of motion with strength, than anything else I had done, whether it was trigger point dry needling or, like I said, foam rolling or Graston tools. So I really started diving into it and looking at the research of it. And it was really shoddy research for the most part, because everything was geared towards just pain modulation. And my thought was like, well, what about range of motion changes? What about function? What about some of the other things that go into why you use a modality? So that really kind of blossomed, and I started using it with athletes and found that A, it would save my hands a ton, but B, there was slightly different, I think, outcomes that they would have from this modality compared to a compressive force like a Graston tool, or a compressive force like cross friction, or different types of things that we do with our hands. So I really kind of saw it as this new kind of divide of compression versus decompression. And the idea of decompression really made more sense when we think about like the physiology of these connective tissues and the way they need to be lubricated with hyaluronic acid, and the way things, tissue slide theories are built into our heads now. So it really was cool, like kind of revolutionary experience in my head. And then just kind of diving in more into the science of fashion and what those things look like has really been like the journey that took off from there in like 2010 to 2014. And then in 2016, we worked with Team USA. That was the Michael Phelps effect of 2016, where you saw the cupping marks on Michael Phelps. So we worked with Team USA in Colorado Springs at the training facility 2 months before the Olympics happened. So that's why that was the big hoopla. And
that's why everybody had hickeys in that
and so
that Olympics.
So really having cupping grow so much since 2016 was kind of our fault, because of the this best swimmer of all time having these marks on him, and what that brought to like the stage of being able to visualize what's going on with some of those things.
Yeah, I wanted to ask you. That's
kind of been the short version of the journey.
Got it.
Go ahead.
Yeah, no, I wanted to ask you about that particular Olympics, because it felt like it started with Michael Phelps, and everyone was like, what is going on with his body, because it left the cupping marks. And then as the Olympics went on, you're just like seeing it in multiple sports. Like it almost like it grew exponentially in like those 2 weeks of the Olympics.
Yeah, totally.
Were you like really busy? Or were you like?
So I had put in some time the year before. So yeah, so the year before I'd spent 2 weeks at Team USA in their Colorado training facility, and we worked a bit with swimmers, but even more with gymnasts. And so gymnasts and swimmers got the most, I think, attention because they have the least amount of clothes on, right? And so we'd done this with some of the wrestling, a lot of wrestlers, a lot of Olympic lifters. And so cut marks were on all these athletes in 2015, 2016. It's just like that was the stage, I think, that someone had the least amount of clothing on that you really kind of saw the effects. So it was nothing new. We had been doing this with motion and teaching myofascial decompression specifically with like the Oakland A's and the San Francisco Giants, and maybe a half dozen NFL teams by 2016. But that's when it really started taking off a lot more.
Yeah, Jay, do you have any questions?
You can keep going, my gardener.
Okay.
I don't want to get that in the background.
All right. Yeah, thank you, Chris. I just wanted to get, this is like something that came from the internet, and it says, how do you introduce the concept of cupping to a patient that may not have any background knowledge of it? Like, what is your spiel to them?
Yeah, for sure. I think the stigma of it is like, oh, you're going to give me a bruise, like, the circular hickey marks. So right away, we want to jump into kind of dispelling the idea that the bruise is what we're going for, and we're trying to create blood flow solely to this area. I mean, those are more traditional narratives. And I think one of the most important things that we've done is kind of shift the narrative out of just stagnation of blood and stagnation of fluids into like, let's get tissues to glide and slide, because that really is what actually changes mobility in a human. And then as soon as possible, introduce some loading to those tissues at the same time, simultaneously, or after you pull the cups off the person. So one of the things I try to like start with a client is like, you're going to see this tissue pull up, and sometimes they get red and sometimes they don't. And it's not because there's tissue is healthy or not healthy. It's just sometimes there's more leakiness in capillary beds than others. And so it's not something that we're going for. We're really more interested in those tissue texture abnormalities before and after, and seeing how the tissue moves with before and after kind of measurements that we're going to use.
Got it. And so like when you're explaining what happens like at the fascia level, are you saying like it kind of pulls it apart, like it, because the word decompression is in the title, so you're saying like the muscle is getting pulled apart from the fascia? Or I mean,
exactly. So
yeah,
we get a lot of those questions of like, are we breaking up fascia? Are we, separating the layers? And really, we came up with the term myofascial decompression because that actually didn't exist as a term until 2008. Like we were at Cal, Berkeley, and we were kind of going through like, cupping has this very traditional, medicine like stigma with it. And so we wanted to steer away from that. And myofascial decompression really describes what the properties of this tool provide the body, because it does lift up, tissues and layers. So when we think about those layers, that superficial fascia to, the adipose going into the deep fascia, and that deep fascia connecting to the epimysium outside the muscle, and then even the perimysium and endomysium inside that muscle, all that stuff is linked up together. And sometimes we lack lubrication between those layers. And that's really what we want to get to the heart of, is like, let's improve the slide glide capability of these tissues by improving the space between the layers as much as possible, because that's what's been shown to improve hyaluronic acid content is compression and decompression and shear forces. So you need shearing along with compression decompression, which this tool does very, very well.
Okay, got it. And then that's where the incorporating movement in with the cupping comes into play. You're trying to get the slide.
Exactly. You're going to get that slide effect. And so those shear forces excite what we call a fasciocyte. So a fasciocyte is this new cell that wasn't even discovered till 2014. And it has been determined that that's the cell that lubricates the space between your connective tissue layers. And so we go a lot into the science of this new idea of lubrication, so much more than the old school thought of breaking up, fascial collagen cross bonding, which we've shown in the science to actually probably not be true and not be possible overall with our manual therapy effects that we thought we were doing.
Got you. And that kind of leads into my next question, which was like, when you first started doing it till now, like what was kind of the major change of thought, or like how have you I don't know, progressed with what you think is going on?
Absolutely. So we've evolved so much. We started teaching this course in 2009, 2010. And that was like one course a year, two courses a year. And then in 2012, we really started shifting more into, I would say, growth of the use of not just movement, but also resistance, right? Because if you think about what's going to not just lubricate the tissues, but improve the tissue tensile strength, meaning our ability to withstand forces and have more resiliency in our tissues, we need to also lay down new collagen. We need the fibroblasts to really kick into overdrive and start to remodel and organize things better. So we can't break up those things, but we can definitely help the organization of the tissues within the body. And that's really the big shift of ideas of movement were great to start with, but we really transitioned and evolved into, we need to load the tissues as well so that fibroblastic activity really takes off and has an organizing and tensile strength effect.
So are you doing resisted exercise with cupping as well? Or is it just trying to get the glide effect?
We do both. And so there's a time and a place, right? There's a time and a place to use a cup just to desensitize tissues, right? We do use a cup every now and then for just pain modulation and neuromodulation, right? Getting somebody to feel safe before doing a movement, getting them to feel safer to touch their toes when they couldn't before without pain in their back or pain in their, hip or thigh or wherever. So sometimes you want to use it for that. Sometimes you want to use it to gain range of motion. So we teach very strategic techniques on how long you're going to leave it for, with how much pressure you're going to use, whether you're gearing it towards pain modulation versus range of motion changes versus actually architectural changes where we're trying to improve tensile strength and load forces on things like tendinopathies and things like that. So those are kind of our three big categories that we look at, because there's lots of uses for it. And it just kind of depends on how much pressure you're using and how, aggressive you're going with it.
Okay. And
Chris,
go ahead.
Have you guys done any sort of, well, actually, let me back up real quick. So I'm actually fascinated by this whole like approach and actually just your story because it's like you were exposed to this and it reminds me of kind of like I took a Mulligan course way back when with him and I remember how some of his techniques came about. You know,
Mhm.
he would get a patient and he would be like, you know, I remember there was one a knee pain guy, Grubby he called him, and he had like some sort of knee pain and he wiggled his knee one way, it hurt, and he wiggled it the other way, and then it didn't hurt.
Yeah, yeah,
Um, and it's just fascinating to hear that, like, you know, you got this performed on you, and you're like, wait, why can't I move, right? And you
yeah,
ask that
absolutely.
question,
Yeah,
um, and then this evolves, and then it now becomes much more, you know, user friendly from it's
mhm.
especially from a therapist standpoint. But
Yeah,
then you go through this evolution where now it's like you're asking more depth and really trying to figure out why and what's actually happening. What kind of studies and stuff are out there which are currently on this, and what have you seen or heard?
yeah.
And then I have a follow-up question to that.
Yeah, absolutely. So the literature, and we dive deep into the literature because I think that's super important to base our foundations off of. But it, you know, we're in the art and science of an application of things that we do. That's the field that we're in, is you have to use the science. If you're not, you're kind of dismissive of things that are going to be better for repeatable outcomes, right? And you're going to guarantee outcomes when you base things on science. So what we really think of as the evolution of the science part of it is that everything, I think, prior to 2015 or so was geared towards pain modulation with cupping. Now, since then, we started doing this imaging research back in 2014, 2015 at UCSF. So we paired up with the Department of Radiology, and some of the studies that we wanted to understand is like, where are the tissue effects? Because prior to that, cupping, we really didn't have a very good gauge of what is happening when you're pulling that tissue up. Are you affecting the muscle at all? We had no answer. I scoured the literature. There was nothing in terms of evidence to say that you're affecting muscle. And a lot of these anti-manual therapy groups at the time were hating on what we were doing with some of the Major League Baseball teams or some of the NFL stuff that was starting to get exposure, because there's like, oh, all you're doing is pulling on the fat and the superficial fascia. And I was like, no, it's not. It's definitely affecting some of the muscle firing potential and some of the ability for like maxillofacial contraction or the, you know, agonist antagonist balance type stuff. And I had nothing to base it off of. So really I got into this research aspect to understand what are the tissue effects when you use something like 250 millimeters mercury versus 500 millimeters mercury. And so the first place that we put a cup on was the upper trapezius, and we stuck a live human in the MRI with a cup on. It was the first time in the history of mankind that this has been done. Like there was no study done for tissue effects like this prior to it, which kind of blows your mind because cupping's been around for thousands of years, right?
Mm-hmm.
You would think that, you know, something in the last 25 years, 40 years would have analyzed the tissue effects of this. But again, this was the first time this was done, and we were blown away at how much of the muscle was pulled into the actual volume of the cup. So not just how deep it affects, but how far that tissue is translating up towards the vacuum pressure of the cup. And so we validated that, yeah, you can definitely have muscle effects, that nobody could really answer that prior to that. But since then, we've really looked at what are the pressures necessary to actually just get to the deep fascia and not affect the muscle, right? Because sometimes you don't need to go hard and heavy on every single client. Sometimes you just need just enough pressure to affect the layers that are going to be a bigger effect on the neuromodulatory system, right? Instead of just trying to beat the crap out of tissue all the time. So we've now done an MRI imaging study on different pressures on different parts of the body and 9 different parts of the body. So we've done TFL, high hamstring, IT band, rotator cuff, upper trapezius, lumbar is our newest study, and we just presented some of that at a international fascial congress in Montreal. And it's really cool to have these answers now that just lacked 5 or 10 years ago. To understand tissue effects and how much pressure affects which layers is so important. And that's some of the stuff that we've done at UCSF Medical School since about 2015. So that's been the big breakthrough in the tissue mechanics area. But then in other literature that's been produced in those last 5 or 7 years has been what pressures are the most effective for actually improving blood flow? Because we didn't have those either.
Mm-hmm.
Like, is it better to use 300 millimeters mercury or 150 millimeters mercury for blood flow? And then what's the time effect? What's the best amount of time to leave a cup on the body to have the most blood flow changes and small inflammatory effects produced because of that? And so that's new literature that just came out in 2018 as well. So what we've done is really kind of synthesize some of this better, more up-to-date, evolved literature into how you would use this in a cupping therapy practice, right? And so it's really, I think, changed the protocol and how long you leave it on for, how much pressure you use, how often you do it. So it's really changing the frequency and dosage of what you're going to do, which is kind of the point, right?
Yeah.
Those are the details that you really need to know to make sound clinical decisions on why, when, and how much you're going to use for that.
Well, I think it adds that whole clinical reasoning component to it, right?
Yeah,
Like
absolutely.
when you do it with what, and you were even saying, like with certain patients, you're going to do maybe you're going to maybe go a little more superficial, and others you're going to have to go a little
Yep,
deeper, and really gaining a good understanding and knowledge of that. So that's
absolutely.
I mean, it really provides good perspective, I think,
Yeah,
rather than just blindly just throwing a cup on and saying, hey, you know, something's happening, and hopefully, you know, I mean, that goes
Yeah.
back to the old days, right, of PT.
yeah,
Put your hands on somebody, and you're like, I hope something is happening, right?
yeah, totally.
And you know, they got better, so what does it matter? Well, no,
Yeah.
we need to understand what's actually happening here.
Yeah,
So
for repeat, it makes repeatability so much easier, right? The human being is complex enough as it is. We want to get as specific as possible to have as much repeatability and outcomes as possible because we're already kind of, on the short end of the stick of really understanding how complex this organism is that we live in.
sure, sure. So my follow-up question was this: anecdotally, what have you seen in the clinic? Like, what would have been like a moment or some sort of aha moment that you've had, where you've been with a patient and you've like done this and just been like, whoa, I was not expecting that. Like, what a crazy outcome.
Yeah, I think really my biggest aha moment in the last 10, 15 years using this modality was on endurance runners with chronic IT band issues.
Mm.
I think when I opened this lens of space and compression, right? Because your IT band syndrome, it's not a friction syndrome the way we used to think it was. It's not snapping past the condyle, it's a compression issue. And we've kind of got swiveled around that pendulum of discussion away from friction and into compression. And when I saw it working so well, this was like 2013, 2014, endurance runners, like I was treating one of the top 10 Ironman women in the world, and she had a lot of IT band issues, and she just couldn't get past like mile 16, 17 when she was doing her training without a ton of irritability, right? And for most people, 16, 17 miles is like, whoa, that's plenty. I don't want to go more than that. But for some endurance athletes, they have to go and they have to train. And to think of the decompression of the space between the lateral femoral condyle, so the IT band, and pulling that tissue away, that was a game changer. And it really changed distance that endurance runners could actually achieve with this one modality and sometimes one treatment. It was really one of those like magical moments, right? Because if you have this periosteal fat around that area with nociceptors that are just getting cranked on because of compression, it doesn't take a lot to decrease that threshold of irritability that they have, and changing that through decompression with this cup on the side of their IT band was a super simple and very effective tool. So to see that kind of like quick immediate effect and such a change in function was super empowering, right? Because if you can take a client and they can tell you what their problem is, and you can touch their pain and say, is that your pain? And that comparable sign, you can take away the pain with something, you have instant rapport build, you have instant buy-in. They'll do any exercise you want them to, which
Yeah.
is really the long-term fix, right? Long-term fix is still load capacity of those tissues. But that buy-in is so important. And I think this tool gives you such a like speedy way into building rapport and building confidence of your client into what you can provide for them from a training perspective.
Yeah, I mean, oftentimes they're coming in, you know, because that load has exceeded the capacity of the tissue, right? And
Yeah,
so
exactly.
you're essentially dealing with, you know, what they want more than anything is just get rid of the pain.
Yeah, yeah,
And
Mhm.
then we're more interested in, okay, the pain's the first step, and
yeah,
then now let's figure out all the other components which are involved with it. You know, is it strength? Is it motor control? You know, what are the other Is it what other mobility pieces are part of this, and just
Absolutely.
trying to integrate all that as
Yeah,
we go along. So it definitely sounds like you're like not dogmatic on on this. Like this is the only, this is the primary way to treat. I mean,
not at
would
all.
you say that, or would you do you blend it in with all the other kind of stuff,
Absolutely. Like, I think this is a really great adjunct to, again, getting somebody to lift more weight than they could without using this modality. Sometimes you get down to the bottom of a deep squat, say you're doing a back squat, and you're getting that anterior hip impingement, and you just can't get past that, right? You have fear, you think something's, maybe causing tissue damage in there, or it's not comfortable, you don't want to load it as much as you could. And this tool has this effect for a short-term modulatory nervous system decrease of pain, and you can go through a bigger range of motion with less irritability, thereby giving you the capacity to load the tissues better, right? So that's really been the evolution. I think the biggest thing that's changed is looking at this thing to, like you said, take away that initial pain, irritability thing to empower someone to be able to do it. And sometimes I don't use a cup. Sometimes I still use my thumb and I dig into TFL before I get into deep squat. Sometimes I'll take a Grasson tool and just do some light, scraping to change again that neuromodulatory effect. So it is a important tool, but it is not the only thing that I use. I think that this tool is different in the sense that it does decompress tissues where everything else we use is mostly compressive forces. So I do pull this out more often than the other things because it makes more physiologic sense, but it is definitely not the only tool that I use in the toolbox.
That actually really hit home with me right now. You are right. Majority of the stuff we do, we're putting our hands and compressing.
Yeah.
And this is
Yeah.
I've never really thought of it that way. That's actually a really cool way of
Yeah.
thinking about it.
Yeah, and I would love, like, when I first started, I was like, I don't want to leave hickeys on people. That's not the point, you know.
Right.
I think it's interesting that this tool is the only thing out there that I've found that can actually do decompression of tissues, right? There's
Sure.
not much else out there. Everything else is compressive. So yeah, if something needs compression, you got 20 other options. When you want to decompress and lift tissues, there's not many options, and this is that great tool that can provide that service for you.
Cool.
Hey, I wanted to ask you, because the first time you had experience cupping was through an acupuncture visit.
Mm-hmm.
Jay and I have been in discussions with a lot of acupuncturists lately, just by chance. We had one
Yeah,
take our course. Hello, Dodie, if you're listening.
cool.
And I was just wondering if you've been in any conversation with the acupuncture community. Do you get any negative feedback because you're using one of their modalities or anything like that?
I think the beauty of social media is we're starting to see that all the professions, chiropractic, acupuncture, massage, PT, naturopath, like DOs, we're all getting closer and closer to looking the same. And that's
Mm,
not a bad thing. That's a good thing because we're starting to get better understanding of the evidence. And if the
right.
evidence says this is the truth right now as we know it, everybody should be kind of getting closer to that truth, is the way I like to describe it.
Yeah.
So I love bridging the gap with an acupuncturist and bringing them into this course and showing them the movement capacity that this tool could also provide, right? I love taking a massage therapist that takes this course and showing them how an exercise paired with some of that soft tissue work is so important for, again, improving tensile strength and laying down new fibroblasts organization of collagen, right? These other ideas I think are blending, and that's what I think we're starting to see a lot more on social media is like we're all kind of looking the same because, well, we should, because we're starting to gear more and more towards evidence.
Your social media account is hilarious, by the way. So I just want to say good job. Are you the one that does that?
Thanks, man. Yeah, I'm still doing it all myself.
Great
I've
job.
tried to like shift it out to someone else every now and then, but I feel like there's a personality to it, and I
Yeah.
like the way my personality has done it so far, and
Mhm.
we're growing a lot, and so at some point I'm gonna have to let it go a little bit. But I love creating and trying to dispel myths, and I think challenge from an intellectual standpoint, like why we do things. Like ask the questions, ask the hard questions, and
Mhm.
question everything you've done. I think that's one of the biggest things that I've really gotten joy out of in the social media world. I
Mhm.
don't love all the things, posting's a pain in the ass sometimes, but I think
Yeah.
questioning and bringing to the forefront why we do things, and really laying down foundations and breaking apart old school dogmatic ideas is the way to go. And it's really been a good growth process, even in my own clinical practice. I practiced so much differently in the last 3 years, I think, than I ever have because of asking myself harder questions, you know, and it's been really a fun journey for that.
You know, I'll go back to the acupuncture thing because it's interesting how you're talking about how everything's kind of starting to blend. And I think, though, the one unique thing about our profession as therapists, we've evolved to really doing more and more research and really challenging a lot of those
Yeah,
standards, like what you're talking about.
totally.
And in talking with some acupuncturists over time, I have heard that you know, they're doing a lot of these techniques, and they're referring to, some stuff which may be like literature from like hundreds and hundreds of years ago,
Yeah,
like old, like, Chinese
yeah,
textbooks and stuff.
totally.
Um, and it's really, one of the things they did tell, one of the acupuncturists I talked to was saying that what we do well is research, and so we're able to put some of the meat around it. And so,
Absolutely.
I think this is fascinating that you've done that in regard.
Yeah, I think it's an important bridge to, build relationships with these other complementary medicine providers. And I think it's really challenging, even in our own profession, right? The scientific rigors of a really well-developed methodology for a study narrows things down to one variable. The problem with manual therapy in general, and also exercise prescription, is there's a lot of other variables still confounding some of the results that we see.
Right.
And if you take those scientific principles of good methodology and narrow it down to one variable and doing it with and without, and then you apply it to the world of traditional Chinese medicine, it's very hard to do, because how are you going to apply these scientific rigors to a medicine where everything is interconnected already and you're never treating one system? You're treating the body, you're treating this holistic approach to medicine. So I think I always say this, like, acupuncturists are like 500 years ahead of us in terms of understanding the mind body connections and how we're starting to appreciate a lot of those biopsychosocial things now, right? The term biopsychosocial is like the biggest thing to blow up in the last 3-4 years. And acupuncturists have been doing this for 500 years, 1,000 years, right? Acupuncturists are 50 years behind the physical therapy and athletic training world and chiro world of evidence in terms of the rigors of methodology and how to narrow down your variables as good as you can, right? They're not going to be perfect. We're not doing a drug with and without. The pharmaceutical studies are easy. Here's a drug, here's a placebo, which one's going to do better? And that's very hard to do when you think about manual therapy studies, even when you think about exercise studies, because there's other things in terms of preconceived notions and what they're doing, and they can feel differences in load. They can feel differences in cupping pressures. They can feel differences in whether you actually put a needle in or if it's a sham. Like, it's pretty easy to know whether you got the actual treatment for some of these things or not, right? So it's very different than a placebo control when you think about a pharmaceutical study for a drug development or something like that.
Cool. Wow.
Yeah, it's complex world, man.
Yeah.
I have a skeptic question for you that we got
Yeah,
on
love
Facebook.
them.
So I was sharing the class with a group. I don't remember which one, sorry. And Bobby J writes, JetSet Rehab Education, thanks but no thanks. Anything with myofascial in its title already raises a yellow flag. In a nutshell, what is the thrust of this course? What are the theoretical underpinnings of this treatment model? So there's a
Absolutely.
lot of questions in there, but
No, it's
I'll let you
beautiful. So
answer.
let's frame it around myofascial, because I think that is one of those like buzzwords that will polarize, I think, groups very quickly.
Yes.
And I think it comes back to people are just not well read on what the newer frontiers of science are in the fascial world, right? So every 3 years, there's a fascial congress, right? And it's, I'll admit, a little bit on the fringe side of science, because you're taking engineers that are trying to do these tissue studies that have no idea about clinical relevance of things, right? But what it is opening these ideas of something like a fasciocyte, right? So the fasciocyte cell was something that I never heard of until I went to one of these fascial congresses. And so this is work coming out of Italy that they're really analyzing using histology slides and looking at some tissues and the distribution of these cells, and the distribution of collagen like density and what we call densification in different parts of the body and how that relates to pain and how it relates to function. So I think a lot of times it comes back to the naivety of not staying up to date on science because it's such a tangential science that we can't even stay up to date on our own like general physical therapy practice. What's best practice and some of the things that look at the current studies for that. It's hard. I think it's challenging to stay on top of the research world in general, just in our lane. If we just have tunnel vision to our rehab science only, let alone go out to these other things like, fascial science or, pain science or these other things that are really taking off. And so I come back to challenge, someone that has a question with that. Well, how much do you know about the shift away from the idea of adhesions and fibrosis and breaking apart these things? That is the old school rhetoric into the idea that, well, we're actually trying to change the slide glide properties of tissues. And that's the main mechanism for it. So when you look at the world myofascial, we're not trying to break it apart anymore. We're really trying to improve glide slide properties and the neurophysiologic effect of what you're doing with it. So it's just kind of catching up the narratives, right? And I think people that hear it and kind of want to poo-poo on it, it's basically because they're staying with the old school narratives and they haven't caught up to date with some of these newer narratives of what we can do in the myofascia and why it is important, right? Myofascial force transmission and how, something in one compartment can affect the other compartment because of the connections of these, tissues.
Yeah. Is there any particular resource you would direct somebody like that to read?
Yeah, I think there's a lot of stuff on the fascial system out there. One of the bigger groups is the STECO group, so STECCO.
Oh yeah,
So
Jay's taking that.
So Antonio Stecco is a physiatrist that was working at NYU, and his sister Carla Stecco is an orthopedic surgeon and anatomy professor, and like basically a PhD looking into fascial research. So, and their father is a physio in Italy, and so like talk about a powerhouse, physio family. Like they are really diving into some of the more important work when it comes to understanding connective tissue, right? So looking at how connective tissue has, myofibroblasts in there and has the ability to actually have small amounts of muscle contraction within the fibers of fascia itself. So things like that, or the idea of, fascial lubrication with this fasciocyte cell and things like that. So I think Stecco is a really good place to start. The other author that's out there a lot is Robert Schleip, and he's a German physiatrist as well. And so Schleip and Stecco are probably some of the big forefront kind of drivers of some of the literature out there. But if you just type in fascial congress, you can go into a very deep, quick rabbit hole of all the different kind of pushing the frontier and these fringe kind of ideas of what fascial science looks like.
Okay, so there you have it, Bobby J. Check those resources out and get back to us. I'd be interested to see if that changes the mind.
Yeah, I think it's a starting point of understanding tissue effects a little bit. We don't have the answers yet on how that relates back to clinical relevance, right? What those tissue behaviors do, and does it have an actual clinical change in our patients? That is something that's going to take another 10 or 15 years. But honestly, we don't really know that for things like eccentrics in a lot of ways. Like some of our ideas of what's going on with eccentric loading are still theories. Some of our ideas of what we're using with blood flow restriction are still theories, like you're wearing the, Owens recovery. Like all these things have a big gap in understanding clinical relevance because those are prospective studies that are needed. And that takes a lot of time and a lot of money. And we just haven't done those yet. But it's not just for myofascial research, it's for exercise prescription research as well,
Yeah.
I'd be fascinated to see how much is happening like when you're doing it, like you said you did an MRI and you saw what it did to the muscle. I'd be fascinated to see if like an fMRI, like what's happening in the brain,
Totally.
and what because I imagine, I mean, any sort of manual care that I've ever seen, you're providing input into the nervous system, right?
Totally.
Even like a movement or an exercise, it's all input, and so to me it's like how much of this is even that pathway that you're affecting higher up.
Yeah, afferent deference is like kind of what manual therapy has been really the narrative's shifted towards anyways, right?
Right.
Like you're trying to have an effect by changing that, information coming up to the central nervous system. So yeah, that's a powerful tool. Like use that peripheral information to help you do more,
Yeah.
And I saw a lot of new literature on using ultrasound too to demonstrate the glide properties, correct? Because I
Yeah,
know
I think there's a,
Shocklock uses that a lot as well.
yeah, there's a lot of cool stuff using ultrasound. The thing I don't love about ultrasound is you can have a really high rate of bias in those studies because just putting a little more pressure or less pressure on a probe changes the caliper readings that you're going to see of those things. That's why we shifted towards MRI. MRI is clean. Anybody can take the images I took and measure it themselves and have repeatability. So when it
Yeah.
comes to like really breaking down barriers for, anti-manual therapy haters, you really got to have something that's concrete and I think, going to be very repeatable. And ultrasound stuff's cool. It's a very eye-opening thing to see and like it gives us possibilities, but it's not as repeatable, I think, as some of the other things out there.
So let me throw something at you here. I mean, and again, this is the clinical side of me,
Mhm.
and again, I'm really excited to take this. How much of this have you used, like with, let's say you've got a patient and you're like, hey, you know what, this looks like some sort of like nerve glide kind of issue, and then you put
Mhm.
them like in a slider or tensioner, but you're utilizing the cup to assist with that.
Exactly. Yep.
Uh, but have you? I'm sure you have, but
Oh,
would you maybe a little bit?
totally. We actually, that's kind of our next frontier of research that we're going to do is actually taking some type of either MRI or ultrasound scan of something like a carpal tunnel, right? It's a very easy
Mm,
spot to put a cup on. And we have these really kind of cool contoured curved cups that are different than a lot of the cups that are out there. So it fits really well right over your carpal tunnel. Because carpal tunnel issues are it's a space issue, right? And so if
yeah.
you can decompress some space in there, you're definitely going to improve that, water hose called your nerve gliding through this little hole. And so that's
Wow.
one of those things that we use a ton of. And so it's great on things like carpal tunnel. It's great on, perineal nerve, posterior to the fibular head. If you're using a light pressure, you don't want to go too aggressive
Mhm.
there, but definitely getting some of the neuralgias and paresthesias to go away and extremities is really, really helpful. Yeah, it's a fun tool for that for sure.
Cool.
I can't. That's yeah. That and this is like changing like a lot of how I think about things because I remember it's been 9 years, Jay, but Jay and I did a study on a tennis elbow where we
Mhm.
treated tennis elbow with scapula stability. But when we
Yeah,
were the part of the roadblocks of that surgery was they needed a mechanism for why it worked. They knew it worked, but in the conclusion of the study, you have to say what your theory is. And then when we brought up fascia, it was just like, no,
yeah.
no, no, give us a real reason, you know. But
Yeah, yeah.
makes me
And
wonder if
breaking down those walls, yeah,
yeah, makes me
it's
wonder if
part of
we
that. Yeah.
went
Here's
went
one
too
that I
soon.
do all the time. So if totally, if someone has a radiculopathy, I'll do this leg distraction with a straight leg raise.
Hmm.
And you would think a distraction on a hot nerve would actually make it more irritable, right? But there's something about pulling that leg and going through a range of motion of a straight leg raise that you can take someone that has like a 30-degree straight leg raise and they'll go up to 65 right in the moment there. And you would think pulling and tensing that nerve by tractioning is going to like cause that nerve to get a little bit stiffer, a little bit more on tension. But it's actually a space issue still, right? Probably somewhere along that neural circuit, there's some compression of that area, and you're taking a little pressure off of it and allowing it to glide more easily. So it's just the idea of space, I think, a lot of times when we think about what our tissues are doing and if they can slide or glide or not.
Yeah, it'd be really cool to do like with nerve conduction, the velocity tests,
Exactly. Yeah,
and
totally.
use
Yeah,
that
that's what
with cupping. That'd be so
yeah,
fascinating.
that's that. You don't steal my thunder, but that's exactly what we're going to do.
Oh, sorry. Well,
Pre and post, like take nerve conduction velocities, do the intervention, and have them do it right after, and then have them come back a week later and do it again and see if there's carryover.
yeah, and then we'll show Bobby J.
Absolutely. Now, there's a lot of skepticism out there because I'm a skeptic as well, but I'm also optimistic of
Mhm.
understand your anatomy and physiology, and that's really what I think our course does. Is it really dives into anatomy and physiology really, really well, and then understand that the pressure you use in a cup is so vital for understanding that. So now we have a pressure gauge on our pump, which is going to kind of change the
Oh,
field
that's so
itself.
cool.
It hasn't really been out there, and we just launched this in September to understand that that pressure gauge is going to give you a much better handle of what depth you're affecting when you use something like a cupping therapy.
Very nice. So, what can people expect from your course in Cabo? Like, what are they going to walk away with? Literally,
Hopefully
like,
a lot of fun. Hopefully a couple hangovers here and there. Having some fun with it.
I'll
I
have a
think,
follow-up question on that. Yeah.
getting educated, I think is great, but enjoying the experience,
Yeah.
I'm all about like having the course be as fun as possible, I think is really one of my main focus points. But
Mhm.
really, I think sitting down and understanding how to have a really good grasp of the current understanding of literature and what that literature looks like in 2022, not the literature of, 10 years ago. Um, and then also understanding that this is going to be a course that builds foundations and concepts so you can apply it to whatever demographic that you see. You don't have to work with athletes to make this tool really valuable. We actually
Mhm.
have NCS therapists that work with neuropopulations that use cups all the time
Wow.
for postural awareness things. So if you have hemiparesis or hemiplegia and you have a postural abnormality, having some awareness and using a cup to build that like haptic sense of the body so that you have a better idea of what is
Oh,
an
wow.
upright posture and things like that. So you can use it for all kinds of different populations, not just the athlete like Michael Phelps, So
Mhm.
I think giving people foundations and concepts so that they can take it to whatever their niche and their demographics that they serve is really the fun of it, right? And that's the fun discussion too, is like opening your eyes to like you can use it for oncology after post-radiation mastectomy, right? And so understanding those tissues and looking at some of the applications for different ideas of than just laying on a table and getting some cupping done to feel good. Yeah.
Got it.
Yeah, I
Got
think
it.
this is where the art of therapy comes in, right? It's like literally
Totally.
like learning this approach and then being like, well, where could I use it and on whom? And then the sky's
Yeah.
the limit based upon how you apply it, and as long as you're using the your clinical reasoning to back that up. So
Totally. Like I'd say 10 years ago, like using it around the genitalia was a contraindication for us, right? Because it just don't mess around down there. But I've
Mm.
since had women's health practitioners say that this tool has opened up so much in their pelvic floor practice
Oh,
that they
wow.
don't have to do so much internal work because this is going to work so differently on some of those fascial aspects from a decompression standpoint,
huh,
right? So from a women's health perspective, they're using it for external mobilization of some of the pelvic floor tissues as well.
huh,
Wow. So that's great.
yeah.
So a lot of cool tangents with the kind of changes in the last 10 years, I'd say.
Okay. So for the listeners out there, this is going to be a certification course, like double certification, correct?
Yeah, so you get
Yeah.
level 1 for one day, level 2 for one day, and then you take a certification exam online afterwards, whenever you want, after you recover
Uh-huh.
from your hangovers or whatever. And then,
Yeah.
it's
And
certified.
speaking of hangovers, it's on your bio, Mezcal Paloma
Oh
is a
yeah,
favorite
yeah.
drink.
I'll
And
have a few of
Jay and
those.
I are whiskey connoisseurs.
Oh
And
yeah,
we've been on Hello Whiskey Docs podcast. We've been on that
cool.
podcast. I was an actual guest.
Awesome.
And then the last course we had in Cabo, one of our students kind of turned us on. He was like a big mezcal fan, and he
Yeah,
went out shopping like all day in Cabo and came back
awesome.
with some bottles and gave some
Nice.
taste tests. So tell us
Sweet.
what are we missing about mezcal as a
I
whiskey?
think I don't love whiskey, but it has a good crossover, right? Because that smokiness.
Yes.
And so when you think about some of the drinks that you've used with bourbon or used with whiskey in the past, substitute a little mezcal, and it just is a new experience. Like my favorite drink, I think that's newer than the mezcal Paloma is now a mescaroni. So it's a mezcal Negroni,
Oh,
right?
wow.
And so it's a totally different type of experience. And I think just experimenting with like trying it in some different cocktails is really fun. So
Yeah,
mezcal's it's got a different vibe to it.
yeah, I
Okay.
think when I was in Cabo and we got exposed to it, I came back and I started drinking my margaritas with mezcal, and
Yeah. Oh yeah.
I love the smokiness of it. It's just it's perfect. Yeah.
Yeah,
Is
I
Totally.
came
If you
back.
like whiskey, yeah, you're gonna like mezcal.
yeah.
Yeah, I just drink it on
Cool.
ice. You know,
That's
honestly, I
awesome.
like that. Well, the part 2 of this show will be recorded over a nice bottle of mezcal in Cabo,
Nice.
and so
Excellent.
that'll be the follow-up episode because I probably have like 10 or 15 questions I want to ask, but I know I don't want
Yeah.
to do this all day.
Yeah, we'll
We'll
blow
give
it
you
up and
some.
have
I
some
know you
more.
got to hang out with your families and all that.
Saturday, so we're gonna go have some fun for sure.
Exactly.
But I appreciate you guys having me on. Thanks
Yeah.
again.
Can you tell everybody where to, find, if they want more information, just like resource, where to find you, where to
Yeah,
follow you, all that.
absolutely. So to find out more about the Cabo course and all that, we even have a link on our website. So cuptherapy.com, real simple. We
Mhm.
used to have our website say myofascialdecompression.com, but nobody can spell. And so nobody
Yeah.
found it. So we simplified it to Cup Therapy. So just go to cuptherapy.com, or our Instagram is also the same, Cup Therapy. So our handle is CUPTHERAPY.
Yeah, and everybody, you should follow it because they don't take themselves too seriously. There's a lot of like
Yeah,
funny memes and stuff that you make. Great job with that, by the way. And
appreciate it.
there's a lot of humor involved, so it's not just all like research studies and stuff like that. It's just a good
Yeah,
account to follow. And then you also put
yeah,
like a lot of your clinical stuff in there, like you
yeah.
kind of pick out
Yeah.
how people out in the
Yep, some
field are
technique stuff.
using it in the clinic.
Mhm.
Yeah, and you're
Totally.
reposting it, which is super interesting. I got a lot of like really cool ideas from just looking at that.
Absolutely. Yeah, we take, the science and we dose it with sugar to deliver it to you with some funniness, and that's what we want to give you guys science, but people love memes, people love to be, entertained on Instagram. And so we're there to entertain while, having some good resources and some good, literature at the same time.
Yeah, I love the one, like the guy that did it on his lips.
Oh, that was so crazy. So crazy. That is a precaution on our list for sure.
All right. So if this is a course that interests you, or if you have any questions for Chris or Jay or I about the course, it's going to be March 10th and 11th in Cabo.
Right.
Go to
Yeah.
jetsetrehabed.com and check it out. There's a lot of details. I want to add, just as added bonus, the course is held on an all-inclusive resort, so you don't have to think about food, beverages, all included in the course. And
Love it.
the students are going to get a free cupping device as well.
Yeah, it
Yeah,
comes with it.
included in the course. So I mean, this is a bargain, everybody. So
Yeah,
check it
it's
out.
gonna be fun.
Yeah, it's gonna be
Be a
fun
great time.
too. We're gonna drink some mezcal.
Just show up. We'll be there. It's gonna be great.
All right.
Excellent. Can't wait. Yeah.
Yeah.
Prepare yourselves. Let's all train from now till then. We'll be ready.
All right. Thanks. Thank you, Chris.
Yeah.
Thanks,
Thank you
Chris.
guys. Take care.
Yeah.
Hasta.